Equipment Lesson 10 covers exposure factors, kVp, mA, and time. These are the prime factors you set before every exposure. Every technique decision you make, every number you enter on that console, determines image quality and patient dose. We cover all four prime factors and their effects, the kVp dose and contrast relationship, mA and mAs, the inverse square law for SID, fixed versus variable kVp technique charts with pathology adjustments, and a complete summary table. 14 minutes. For factors set before every exposure. The registry tests. Each one individually and in combination. kVp, kilovoltage peak. Controls beam energy, penetrating power. Primary controller of beam quality. Affects contrast, density, and patient dose. Higher kVp equals more penetrating beam equals more gray scale, lower contrast. Typical ranges, chest 110 to 125 kVp, extremities 50 to 70 kVp. mA, milliamperage. Controls tube current, electrons per second. Primary controller of beam quantity. Higher mA equals more photons equals more density equals more dose. Does not affect beam quality. Exposure time. Controls duration. Multiplied by mA to give mAs, the total dose quantity. Short time reduces motion. Blur. AEC automatically selects time in most digital departments. And SID, source to image distance. Controls beam intensity. At the detector by the inverse square law. Standard table. 40 inches. Chest, 72 inches. Long. This chart shows two lines as kVp rises from 60 to 120. Both relative patient dose and relative image contrast fall together. That is the essential kVp relationship, higher kVp reduces both dose and contrast simultaneously. kVp controls beam quality, mean photon energy and penetrating power. Higher kVp photons pass through tissue more easily, more Compton scatter, more gray levels, lower contrast. Lower kVp, more photoelectric absorption. Higher contrast, more black and white differentiation. The contrast trade-off has clinical implications. Chest. Radiography, high kVp, 110 to 125, for long scale. You want many gray levels to show both lung detail and mediastinum simultaneously. Extremity radiography, lower kVp, 55 to 65, for short scale. You want sharp black and white bone definition. And on dose, higher kVp means more beam penetration per photon, fewer photons absorbed in tissue, lower patient dose. mAs is the single best predictor of patient dose in radiography. The relationship is direct and linear, double mAs, double density, double dose. Have mAs, have density, have dose. No exceptions. mA controls tube current, electrons per second crossing the tube. It does not change beam energy or quality. The mAs reciprocity law, any combination of mA and time that produces the same mAs gives equivalent exposure. 200 mA at 0.05 seconds equals 10 mAs, 100 mA at 0.1 seconds equals 10 mAs, 50 mA at 0.2 seconds equals 10 mAs. All equivalent density. All equivalent dose. Use this to your advantage, select the highest mA station available and the shortest corresponding time. High mA. Plus short time minimizes motion blur while maintaining. Required mAs motion is the most common cause of repeat exposures, and every repeat is 100% additional dose. AEC selects mAs automatically in most digital departments. The radiographer sets kVp and mA station. The intensity of radiation decreases by the inverse square of the distance from the source. Double the distance. Intensity drops to 1/4. Triple the distance. Intensity drops to 1/9. The visual diagram on this slide shows 4 distances. At 1 unit of distance, intensity is 100%. At 2 units, 25%. At 3 units, 11%. At 4 units, 6%. The drop-off is dramatic and nonlinear. 2 standard SIDS and their clinical purpose. 40 inches, 100 centimeters, is the table standard for all tabletop and Bucky radiography. Technique charts are calibrated to this distance. 72 inches, 183 centimeters, is the chest standard. The longer SID reduces cardiac magnification and lowers patient skin dose. It requires more mAs than the 40-inch equivalent, but the trade-offs are clinically justified. For portable radiography, measure and document the actual SID used. Compensate mAs with the direct square law. New mAs. 2 approaches to technique selection, and the registry tests both. Fixed kVp technique. kVp is fixed for each body part. mAs varies with patient thickness. Use the highest kVp appropriate for each anatomical region. Chest, 110 to 125 kVp fixed. Abdomen, 70 to 80 kVp fixed. mAs. Adjustments of 25 to 30% for patient size variations. This is the standard approach in modern digital departments. AEC handles mAs selection. Fixed kVp works perfectly. With AEC variable kVp technique, kVp varies with measured part thickness. mAs kept relatively constant. Requires caliper measurement of every patient. Difficult to standardize. Contrast changes with every kVp change. Less common in digital practice. A film-era approach largely replaced by fixed high kVp technique combined with AEC. Technique chart standardize exposures across patients and radiographers. For components, every chart includes body part and projection, kVp, mAs or mA plus time, SID. Grid use, and AEC chamber selection. Pathology adjustments are registry tested directly. 2. Categories. Additive pathologies increase tissue density, require more mAs, ascites, which is fluid accumulation in the abdomen. Pneumonia. Plural. Effusion. Atelectasis. Paget's disease. Edema. Cardiomegaly. All of these add density to the body part. The beam must work harder to penetrate. Destructive pathologies decrease tissue density, require less mAs. Emphysema, air replaces tissue. Pneumothorax. Bowel obstruction with gas. Cachexia. Osteoporosis. All of these reduce tissue density. The beam penetrates more easily. The memory rule, additive pathology ADDS to attenuation. Add mAs, destructive pathology destroys tissue, reduce mAs. 7 interactions. Know all of them. Increasing kVp, density increases, contrast decreases. Patient dose decreases, more gray levels, better penetration. Decreasing kVp, density decreases, contrast increases. Patient dose increases, short scale, more black and white. Increasing mAs, density increases proportionally, dose increases proportionally. No effect on contrast scale or beam quality. Decreasing mAs, density decreases, dose decreases. No contrast effect. Increasing SID, density decreases by inverse square law. Magnification decreases, geometric sharpness improves, skin dose decreases. Must increase mAs to maintain density. Adding a grid, density decreases, grid absorbs primary beam, contrast improves because scatter is removed. Dose increases, must multiply mAs by Bucky factor. And decreasing SID, density increases, magnification increases, sharpness decreases, skin dose increases. 3 exposure factor questions in ARRT format. Think before the answer appears. The answer is C, decrease mAs by approximately 50%. The 15% rule, increasing kVp by approximately 15%, from 70 to 80 kVp, has the same density effect as doubling mAs. To maintain the same density while raising kVp 15%, have the mAs. The trade-off. Slightly lower contrast, acceptable in digital imaging where window and level allows post-processing contrast adjustment. The answer is C, 80 kVp, 10 mAs, 72-inch SID. 3 factors simultaneously reduce patient skin entrance dose. Higher kVp, more penetrating beam, fewer photons absorbed in skin. Lower mAs, fewer photons total. And longer SID. The tube is further from the patient's skin, the inverse square law reduces intensity dramatically at the skin surface. All 3 act together in option C. The answer is C, increase mAs. Ascites is peritoneal fluid accumulation that dramatically increases the thickness and density of the abdomen. It is an additive pathology, more tissue to penetrate. The standard technique will underexpose. mAs must be increased by 50 to 100% depending on the volume. Even on AEC systems, mAs increases automatically. But understanding why is what the registry tests. You covered all 4 prime factors, kVp, mA, time, and SID, with their effects on density, contrast, and dose. The kVp dual chart showing dose and contrast falling together. mAs and the linear dose relationship. The inverse square law visualization. Fixed versus variable kVp. Technique. Technique charts with pathology adjustments, including additive and destructive categories. And the complete exposure factor interactions summary table.